We need a capacity generator. I'm Jeff Dreher. I'm an emergency physician and I'm concerned about our overcrowded healthcare system. We have a problem, and this has been going on my entire career. We have absolutely no capacity. And in the emergency department, this is especially dangerous. Why? Because patients are waiting for care. Waiting causes poor quality, and our staff is burning out. But what can be done? I personally have devoted the last 20 years to investigating this problem and have found a commonsensical solution, one that is easily implemented. In this short video, you're going to learn how big this problem is and what we can do to fix this problem now. In my last video, Healthcare's Self-Perpetuating Crisis, I explored why our system is chronically out of capacity, overcrowded, and short-staffed. So in order to solve this capacity issue, we really need to understand why the problem occurred and why it's not been resolved. This understanding will open a path leading us to the solution. And the root cause of this problem is a financial constraint. Hospitals have a low operating profit margin of only 2 to 4%, and at times it's been negative and it is very variable. So because the margin is so low, they try to contain costs, the administration, and they do this by adjusting staffing because staffing is the biggest operating expense at 48 to 56% of all operating costs. To do this, it drives up the hospital occupancy rate, usually above 85% because that's where the hospital is profitable. And there's a downside to this. It causes waiting. Anytime you run something at a high occupancy, things are going to wait for that resource. And our bed resources are the biggest highly occupied resource in the hospital. Because they wait, quality suffers. The staff doesn't like working in this. It's hard to work at high capacity all the time, so they're burning out, and patients that wait too long for care leave. So all of this causes overcrowding, boarding, and ambulance diversion, which further decreases revenue and increases costs, which further drops our margin. And there's an inertia to this. It just keeps spinning around, and I call this institutional inertia. So to ensure profitability, administrators keep the hospital occupancy rate above 85%. The graph on the left depicts this. Administrators frequently adjust the number of staff and the number of beds open to keep the ratio about 6 to 1. But this has a huge negative downside. So the big downside of a high hospital occupancy rate is that it causes waiting. You can see above 80% whenever the occupancy rate of the hospital beds, or any resource for that matter, is above 80%. The waiting for that resource increases exponentially. And this is pretty much like the law of gravity. It's pretty set in stone. And this waiting is what's causing harm. This is causing our overcrowding because it's just a big pile of patients that keeps backing up. And this is the root cause of our problem. We need to solve this issue in order to solve our problem with overcrowding. I explained this problem in greater detail when I actually recorded that session. So if you have any questions, go back to that session. It's on my YouTube channel. So does your hospital have a capacity issue? Are you overcrowded? How do you know? Well, I can tell you right now, if you walk out into your emergency department at 2 o'clock in the afternoon and you have more than 20 people in your waiting room, you have got a capacity problem. But it's better to quantify it. What's the frequency? How severe is it? Is it causing harm to your staff or to your patients? Is it easily detectable? Is it managed at all? Do you have any metrics? So metrics are a good way to tell how bad things are. Are you super overcrowded or not? If your ED admission length of stay is a lot larger than 4 hours, you know you have a problem because you're not able to get these admitted patients upstairs. ED discharge over 3 hours. Patient left without being seen over 2%. If you're diverting, if you're boarding, if you've got quality issues and outliers, these are all indicators that you've got a problem. And these metrics will help you quantify. So now that you've gauged the severity of your problem, the next question is, are you ready for change? What will you gain and what will your institution gain by solving this problem? And do you have a desire to change? Because change can be very difficult. Are you sick and tired of being sick and tired? I can see all the charge nurses waving their heads because, yes, they are sick and tired of working in an overcrowded, chaotic emergency department and hospital. The next question is, has anyone fixed this problem successfully? Have they had sustained results? The last question is, does your organization and do you have the bandwidth and is the timing right to make the change? Is it now? If not, then when? So why do we need to fix this problem? Because serious harm can result from waiting for care. So this problem needs fixed. Waiting can cause severe harm. This is a very unfortunate case. This is a high school senior who had a full ride scholarship to an Ivy League school and a promising future being an Olympian. He developed a scratch on his leg, and over the weekend that scratch worsened, and he went to the emergency department at noon on a Monday, where he waited 12 hours for care. That scratch was not just a minor problem. He had necrotizing fasciitis, which is the flesh-eating bacteria, and the treatment of this is amputation. He left the hospital 3 months later with no legs. This should never, ever happen to anyone, and this is why we need to fix our overcrowded healthcare system. Waiting for care is also a source of poor outcomes. So if you wait for care in an acute MI, say the diagnosis is delayed because things aren't lining up, the cath lab's not in, some reason the patient's not getting transported, it can actually cost CHF. Every 30-minute delay can actually increase your mortality 7.5%. And CHF's a miserable disease. You're short of breath most of the time, you're on diuretics, and your lifespan's decreased. Stroke, the outcome can be much worse. Delay in diagnosis and care can result in you being hemiparetic, paralyzed on one side, not able to speak, in a wheelchair with a Foley, drool pad, and a diaper and a feeding tube. What a miserable way to live. And yet, if this could have been treated more rapidly, the outcome could have been much, much different. So why do we need to improve our system? Who is going to benefit? Well, patients are going to be benefiting because it prevents never events. It also improves outcome and will also improve patient SATs. Our staff is going to benefit. It's going to improve the health of our staff and the retention of our staff. Our current formula of stress plus working short-staffed is a formula for chaos and burnout, and we've had enough of that. So where can we improve our quality the most? Well, in the emergency department, because it is the #1 admission source, if we can get to patients more rapidly, the quality of their care increases dramatically. 65 to 75% of all admitted patients come through the ED. And the next question is there any financial impact? It's huge. I'm going to show you on the next slide. So you know the financial margins are tight, and these tight margins are the driving force behind the high occupancy rates, staff shortages, overcrowding, and poor quality. So have you ever wondered what is the cost of running an inefficient ED? Because if we improve it, we can certainly recoup these costs. Well, ERs lose money when patients leave without being seen, ambulances are diverted, and staff turns over. There's also dollars lost from poor quality and market share losses. So the total loss adds up to about $13 million annually. Imagine $13 million in net profit added to the bottom line. That pays for a lot of staffing and a lot of innovation. So whenever you present a PI proposal to your hospital administrator, make sure that you mention these costs and include these, because this is what he wants to know, that in addition to improving quality, patient care, and patient SAT scores, you'll also be adding to the bottom line of the hospital. So by improving the system that delivers care, we are going to improve our reputation. Our rankings and Leapfrog and CMS are going to go up. Our malpractice risk is going to go down. Revenue is going to increase, and market share is going to increase. So what kind of results can we expect? So this is the results I've had at one hospital where I employed the methodology I'm going to show you. We've actually were able to drop length of stay by 2 hours for ED admitted patients and 1 hour for ED discharged patients. And this is significant. So by decreasing the length of stay of 2 hours for 50 patients and decreasing the length of stay by 1 hour for 130 patients, this is adding 280 staffed bed hours per day. And this is palpable. When we began the project, the ED was chaotic. There was a lot of boarding, there were a lot of patients in hallways. At the end of the project, we actually had capacity. We had room for patients. And at the end, really in reality, it's like adding a fully staffed 12-bed ED pod to your ED. Imagine that kind of capacity. You could see another 88 patients per day. And this hospital actually did see more patients and dropped their left without being seen. So before we started the project, they had 40 patients a day walking out. That was 12.8% left without being seen. After the project started, we were able to drop this to 4 a day, and that really drove up revenue. It increased the entire hospital revenue by 9%. I've never seen this kind of results. This is amazing. So how did we get such great results? Well, I'm going to give you a hint of the methodologies that we used on the next several slides, but I'm going to go in this much greater detail on further presentations. First of all, we use something called the theory constraints. It's where they look for where is the bottlenecks in your system. What is the resources or the personnel, or what is the constraint? How can we optimize that person or that system to make it run better? And we do this by applying lean to the constraint. So how does lean work along with this system of TOC? Well, we use lean to improve those bottlenecks and remove the constraints and manage them. I just wanted to give you a taste of the improvement because I know that you've been wanting to know how we're going to do this, where we're going to use lean and TOC together to decrease variation, improve how our system works. It's really a great system. It's just amazing the results you can get by applying lean to the actual bottleneck. So if you have any questions, please reach out to me. Here's all my contact information. I have videos on YouTube that will help explain how and why we are improving emergency departments and hospitals. And if you have any questions, just text my cell. And I appreciate your attention and see you on the next video.